Cyclic vomiting syndrome. Jennifer M. Cornwell. Do basics. Description: an idiopathic chronic functional GI disorder characterized by discrete, recurrent, stereotypical paroxysmal episodes of high-intensity nausea and vomiting lasting hours to days, separated by symptom-free intervals. Subsets: cyclic vomiting syndrome, CVS, plus 2 or more neuromuscular disorders in association. Catamenial CVS, associated with menstrual cycle. CVS has 4 distinct phases: interepisodic, symptom-free period, prodromal, often marked by nausea with or without abdominal pain, able to take oral medications, minutes to hours. Vomiting, nausea, vomiting, and retching. Recovery, nausea remits and patient recovers appetite, strength, and energy. 1b. Epidemiology: prevalence 0.042% in general population. Whites affected more than other races. Predominant sex, female. Male, 55:45, more common in children. Mean age of diagnosis is 5 years in children and 35 years in adults. Average of 3 years from symptom onset to diagnosis. Etiology and pathophysiology: strong link between CVS and migraine, with similar symptoms, frequent family history of migraines, and effectiveness of anti-migraine therapy. Unknown etiology. 1. Proposed mechanism: heightened neuronal excitability owing to enhanced ion permeability, mitochondrial deficits, or hormonal state. Increased susceptibility to physical or psychological trigger. Release of corticotropin-releasing factor, CRF. Vomiting perpetuated by altered brainstem regulation. Sustained vomiting. Possible maternal inheritance, based on family history of migraines and linked to mitochondrial DNA, mtDNA, mutations. 2. B. Multiple theories. GI motility. Dysfunction: autonomic dysfunction, sympathetic. 1. B. Food allergy or intolerance. Genetics: likely matrilineal inheritance, especially with childhood onset A3243G or other mtDNA mutations including mitochondrial dysfunction. 2. B. Ion channel mutations. Several polymorphisms have been identified. 165119T more common in children with CVS. Risk factors: family history of migraine, headaches, depression and/or anxiety, chronic cannabis use, possibly food allergies or hypothalamic pituitary adrenal axis dysfunction. Commonly associated conditions: irritable bowel syndrome, 67%, headaches, 52%, motion sickness, 46%, migraines, 11–40%. Seizure disorder, 5.6%. Cannabis use diagnosis history: children often present with bilious emesis, 83%, severe abdominal pain, 80%, and/or hematemesis. The North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition consensus criteria for diagnosing CVS: at least 5 attacks in any interval or a minimum of 3 attacks during a 6-month period. Episodic attacks of intense nausea and vomiting lasting 1 hour to 10 days and occurring at least 1 week apart. Stereotypical pattern and symptoms: vomiting at least 4 times per hour for at least 1 hour during attack. Return to baseline between episodes not attributable to another disorder. Rome 3 criteria for adults: stereotypical onset, acute, and duration, 1 week. Of vomiting episodes greater than or equal to 3 discrete episodes in the prior year. Absence of nausea and vomiting between episodes. Supporting criterion: history or family history of migraine, headaches. Adult hallmarks: prominence of epigastric or diffuse abdominal pain, increased prevalence of anxiety and depression, normal or rapid gastric emptying, successful suppression of attacks by chronic amitriptyline. Therapy: 1. B. Physical exam: evaluate for dehydration, seen in 30%. Orthostatic hypotension, tachycardia, decreased skin turgor. Dry mucous membranes: general physical exam, often otherwise normal. Differential diagnosis: GI disorders, GERD, Helicobacter pylori, cholelithiasis, pancreatitis, obstruction, gastroparesis. Neurologic disorders: migraine, headaches, Chiari malformation, intracranial mass. Renal disorders: nephrolithiasis, obstruction. Metabolic and endocrine disorders: porphyria, Addison disease, diabetic ketoacidosis, hyperemesis gravidarum, pheochromocytoma. Behavioral disorders: Munchausen by proxy, anxiety, bulimia nervosa, depression, pregnancy, cannabinoid abuse, cannabis hyperemesis syndrome. CHS symptoms include episodic nausea, vomiting, abdominal pain, and compulsive bathing with hot water. 3b. Any child with suspected CVS should be evaluated for a possible metabolic or neurologic etiology if child is 2 years of age. Vomiting episodes are associated with concurrent illnesses, prior fasting, or increased protein intake. Any focal findings on neurologic exam, hypoglycemia, anion gap, metabolic acidosis, hyperammonemia, or other findings suggestive of metabolic disorders. Diagnostic tests and interpretation. CVS is a diagnosis of exclusion. 2b. Tests help rule out other diagnoses and exclude complications. Initial tests: lab, imaging, electrolytes, hypokalemia. Addison disease exhibits hyponatremia and hypoglycemia. CBC, hemoconcentration and leukocytosis, amylase and lipase, pancreatitis, ESR, hepatic transaminases, hepatitis or gallbladder disease, urinalysis, granular casts, ketones, urine drug screen, THC. False positives can occur, especially after 4 PPI administration. 3b. Pregnancy test: lactate, ammonia, amino acids, urine organic acids, adrenocorticotropic hormone, particularly for acute episodes in children, to exclude metabolic disease. Upper GI series to exclude malrotation. Abdominal US to exclude transient hydronephrosis, gallstones, and ureteropelvic junction obstruction. Esophagogastroduodenoscopy, EGD. If active hematemesis is present, follow-up tests and special considerations. Counseling, behavioral health for management of anxiety, depression, eating disorders, or cannabis abuse. If applicable, CT or MRI of head. Assess for structural lesions of the brain or causes of increased ICP. CT of the abdomen and pelvis. Evaluate biliary and urinary tracts to exclude structural causes. Diagnostic procedures / other EGD, to evaluate for clinical suspicion of peptic ulcer disease or signs of hematemesis. Electroencephalogram, seizure disorder evaluation. Gastric emptying studies, exclude gastroparesis. 1b. Autonomic testing, neuropsychiatric testing. Treatment: general measures, patient reassurance, avoid triggers, stress, sleep deprivation, chocolate, cheese, monosodium glutamate, red wine. 4a. Non-stimulating environment, relaxation techniques and psychological testing. Avoid recreational drugs, marijuana. Medication: first-line lifestyle modification for episode prevention, drink sufficient fluids, eat regularly without skipping meals, exercise regularly. 5b. Avoid sleep deprivation, triggering foods, and motion sickness to reduce episode frequency. Consider prophylactic pharmacotherapy if an affected child is having repeated episodes requiring frequent hospitalization or school absences. Prophylactic medications decrease frequency or severity by 50%. Many prophylactic medications for CVS are pregnancy risk category C or greater risk. Therefore, discussion of risk versus benefit of treatment during pregnancy should be discussed with these patients. Amitriptyline, 67-82% children greater than 5 years, 0.2 to 2.0 mg/kg/day, not recommended for children 5 years. Slow titration over 2 to 3 weeks to avoid side effects. Cyproheptadine, 39-66% children 2 to 5 years, 0.25 to 0.50 mg/kg/day divided bid TID, appetite stimulant, usually first-line treatment for children 5 years, especially if associated with migraines. 4. Apropranolol, 57% children, 0.5 mg/kg/day divided bid TID, adults, 10 to 20 mg/day bid to TID, especially if associated with migraines. 4. Adjuncts, antiemetics, anticonvulsants, mitochondrial supplements, tricyclic antidepressants, calcium channel blockers. 5. Topiramate, adults with CVS and chronic headaches, 20 to 100 mg daily. 4. 2 mg/kg/day divided bid. 5. B. Ondansetron, children, 0.3 to 0.4 mg/kg dose, 16 mg, Q6H, adults, 4 mg 4/po Q68H lorazepam, children, 0.05 to 0.10 mg/kg dose 4, not to exceed 4 mg/dose, adults, 1 mg po QID to reduce anxiety, 4, A. Sumatriptan, patient greater than 40 kg, 20 mg. Intranasal PRN second line. Prophylactic phenobarbital, 79% 2 to 3 mg/kg/day erythromycin, 75% 20 mg/kg/day divided bid TID valproic acid, 10 to 40 mg/kg/day, avoid if possible and substitute adjunctive mitochondrial supplements. 5. B. Levetiracetam, 500 to 3000 mg daily adults. 4. A. Zonisamide, 100 to 700 mg daily adults. 4. A. Pizotifen, 0.25 mg bid TID. 5. B. Flunarizine, 5 mg once a day. 5. B. Mirtazapine, 7.5 15 mg once at night. 5. B. Aprepitant, twice weekly 40 kg equals 40 mg, 40-60 kg equals 80 mg. Greater than 60 kg equals 125 mg. 5. B. Erythromycin, 20 mg/kg/day divided 4 times in a day. 5. B. Supportive seek to use 4 rectal or dermal medications to decrease repeated vomiting. 5. B. Diphenhydramine, children, 1.25 mg/kg/dose Q6H, not to exceed 300 mg/day, adults, 25 to 50 mg Q46H PRN aprepitant, 30 minutes before vomiting, day 2 and 3 if 15 kg equals 80 mg/40 mg/40 mg, if 15-20 kg equals 80 mg/80 mg/80 mg, if greater than 20 kg equals 125 mg/80 mg/80 mg. 5. B. Metoclopramide, 0.1 mg/kg/dose Q6HR. 5. B. Chlorpromazine plus diphenhydramine, 0.51.0 mg/kg. Q8HR. 5. B. Ketorolac, 0.51.0 mg/kg/dose 10 mg Q8HR. 5. B. Hydromorphone, children, 0.015 mg/kg/dose 4 for 1 dose, adults, 2 to 4 mg po PRN or 0.5 to 2.0 mg IM/SC for 1 dose. Rescue therapy fluids, adequate caloric intake, antiemetics, sedative medications. 5. B. Most episodes, 72%, end with premonitory sleep and therefore induced sleep can cause symptomatic relief and may shorten an episode. 5. B. Issues for referral: regular behavioral health appointments and consultation with a supportive gastroenterologist can decrease episodes of CVS and reduce inappropriate pharmacotherapy. Additional therapies: relaxation techniques, deep breathing, biofeedback, guided imagery, complementary and alternative medicine, coenzyme Q1010 mg/kg/day divided bid for prevention. 5. B. Up to 300 mg daily. 4. A. L-carnitine 50-100 mg/kg/day divided bid for prevention. 5. B. Up to 3 grams daily. 4. A. Riboflavin 10 mg/kg/day divided bid for prevention. 5. B. While marijuana is a potential treatment for intractable vomiting, regular use may cause cannabinoid hyperemesis syndrome, CHS. 3. B. Admission, inpatient, and nursing considerations. Admission criteria / initial stabilization: dehydration requiring greater than 2 L of 4 fluids. Failure of outpatient management: increased anion gap that reflects severe dehydration or metabolic decompensation. 4 fluids or 4 medications: lorazepam 1 to 2 mg 4Q3H. Main approach to induce sleep most effective in acute crisis: 4 fluids. Replacement of ongoing losses. 5–10% dextrose-containing fluids or normal saline with added potassium to attenuate any metabolic crisis. Nursing: decrease stimulation, avoid noise and bright light. Supportive care: encourage relaxation techniques. Avoid unnecessary interruptions during sleep. Discharge criteria: vomiting and electrolyte imbalances resolved, pain managed with oral analgesia, euvolemia, appropriate oral intake, ongoing care, follow-up recommendations, patient monitoring, weekly appointments for severe cases, monitor for hypokalemia, acid-base disturbances, and ketosis if ongoing emesis. Regular outpatient visits for support. Diet: foods rich in carbohydrates, vitamins, and minerals. A low-amine diet may help in children. Limit fats and spicy foods. Avoid trigger foods, chocolate, cheese, and monosodium glutamate. Consistent meal schedules maintain good hydration. Patient education: a vomiting diary identifies potential triggers in 75% of children. Stress management, sleep hygiene, regular, moderate exercise. Cyclic Vomiting Syndrome Association website, www.cvsonline.org. Prognosis usually lasts 2.5 to 5.5 years. Vomiting resolves in 70% of children. Many continue to have somatic symptoms, headache, abdominal pain. 35% develop recurrent/migraine headaches. 50–75% of patients treated prophylactically are asymptomatic at 1 year. 13% are non-responsive to therapy. Risk factors for non-response include poorly controlled migraines, psychiatric conditions, chronic narcotic use, and marijuana use. 4a. Complications occur during vomiting phase: dehydration and hypovolemic shock, electrolyte derangement, including the syndrome of inappropriate antidiuretic hormone, hematemesis, peptic esophagitis, Mallory-Weiss tear, weight loss. References: 1.